a los doctores Eric Alexanderson y Aloha Meave por la invitación. Mi nombre es Guillermo Sagún, soy cardiólogo ecocardiografista y director médico del Hospital de Cardiología en Monterrey. Me acompañan en la coordinación de este webinar el doctor Enrique Alexander Berrios. Él es médico internista, cardiólogo, doctor en ciencias médicas y es líder de la clínica de miocardiopatías en el Instituto Nacional de Cardiología Ignacio Chávez. También adscrito al Servicio de Cardiología y jefe de investigación en el Hospital Español de la Ciudad de México y editor en jefe de la revista Cardiac Image Update. Me acompaña también en la coordinación la doctora Isabel Carvajal Juárez, médico nuclear, especialista en cardiología nuclear, en PET y CT, que está adscrita al Hospital de Especialidades del Centro Médico Nacional Siglo XXI y al Instituto Nacional de Cardiología Ignacio Chávez. Le agradecería en primer término al doctor Berrios si fuera tan amable de presentar a nuestra primera ponente, la doctora Dorbala. Doctor Berrios, por favor.
Gracias, muy buenas tardes a todos. Muchas gracias por la presentación, doctor. Y bueno, nuestra primera ponencia estará a cargo de la doctora Sharmila Dorbala. Ella es especialista en medicina cardiovascular y radiología, jefa del departamento de cardiología nuclear del Hospital de Brigham and Women's y además de eso es profesor asociado de radiología del Harvard Medical School y presidente de la Sociedad Americana de Cardiología Nuclear. Además de ello, ella es experta en estos dos temas, amiloidosis y sarcoidosis cardíaca. Por lo tanto, escucharemos esta interesante plática de abordaje multimodal de estas dos enfermedades. Hello, doctor.
Hi, good afternoon, everyone. Can you hear me okay?
Yes.
And you see my slides, right?
Yes, we can see them.
Okay. Hi, good afternoon, everyone. So first of all, I would like to thank Dr. Eric Alexanderson and Dr. Aloha Meave for inviting me to this conference. I hope all of you are doing well and being healthy, taking advantage of Zoom conferences and working from home at this time. So my topic today is to discuss multimodality imaging of cardiac sarcoidosis and amyloidosis. So there are three major roles for imaging in evaluation of sarcoidosis and amyloidosis. The first role is to diagnose the disease. The second role is to stratify risk. And the third role is to guide management. Sarcoidosis is a systemic disease that is frequently underdiagnosed. It can present as heart block or ventricular tachyarrhythmia. Sometimes sudden death is a first sign. Early treatment may improve prognosis. Because it is a patchy disease, endomyocardial biopsy has a low diagnostic yield. I want to share with you an example of a patient. 49-year-old African-American man with history of lymph node biopsy-proven sarcoidosis who presents for evaluation of syncope. He underwent a stress test that was negative for ischemia, good workload. ECG was normal, echo was normal, cardiopulmonary exercise testing was normal, Holter monitoring was normal. Cardiac telemetry revealed narrow complex tachycardia consistent with AV nodal reentrant tachycardia. The question is, I think you can use your chat box there. How many of you think this man has cardiac sarcoidosis? Go ahead and chat. Yes or no? Isabel, maybe you'll have to look at the chat box. I can't see it here. Okay, a lot of people I see are saying no now. I can see that. Okay, so the third option, actually, I forgot to mention, need more information. So somebody listed that. So basically, he does have systemic sarcoid. All the cardiac testing listed here is negative. And the question is that sufficient? And I think the answer would be need more information. If you look at the heart rhythm consensus recommendations, you can diagnose cardiac sarcoid by histology, endomyocardial biopsy, or in a patient with systemic sarcoid, you need steroid or immunosuppressant responsive cardiomyopathy or heart block, unexplained low ejection fraction, unexplained ventricular tachycardia, or heart block, Mobitz type 2 or third degree AV block. What about the other societal guidelines? So if you look at the SNMMI, ASNIC, and Heart Rhythm Society guidelines, because our patient does not have any of these, the question is, what do you do next? The next is you could look at imaging findings on PET or MRI or gallium. So these guidelines suggest that in patients who have unexplained palpitations or syncope, where there is histologic evidence of extracardiac sarcoid, then this is considered an indication for FDG PET. The Heart Rhythm Society says that in patients with a biopsy-proven extracardiac sarcoid, if the symptoms are positive, then you can consider advanced imaging with MR or FDG PET. There's another guidelines, which is from the EANM and ASNIC together. In that guidelines, they say that if you suspect sarcoid because of extracardiac sarcoid and symptoms of palpitations, the first preferred test is cardiac magnetic resonance imaging. If that is normal, you follow up clinically. Very rarely, even with a normal MRI, you'll go on to an FDG. If MRI is abnormal or unavailable or contraindicated, then these patients become candidates for FDG. If the FDG is positive, you treat the patient with immunosuppressive therapy or ICD. If the FDG is negative, but perfusion imaging is positive, so this is scar tissue, or MRI shows LGE, late gadolinium enhancement, then those patients could be candidates for ICD. So the patient went on to have an MRI. Here you can take a look at the images here. They look completely normal, and cardiac function is also normal. No late gadolinium enhancement, and T2 weighted images show no edema. So the next question is, what do you do after this? Your MRI is completely normal. What do you do? Are you done? So the question was whether he has cardiac sarcoid. So they went ahead and ordered an FDG study. Typically, we perform a perfusion and an FDG scan. Perfusion, this is SPECT-CT with SESTEMIB. FDG shows focal uptake in the lateral wall. But when you look at the partial body FDG images, you can look at all the lung uptake and the lymph nodes in the mediastinum. So now the question is, based on this finding that he has focal uptake in the lateral wall, would you give him an ICD? So this EP doctor called me and we discussed the case at length, and we said, in the absence of a perfusion defect, focal uptake, particularly in the lateral wall, can sometimes be a false positive study. More so because the MRI was completely negative. So we were not confident that this is a real abnormality. So we said there's uncertainty here. So what are the indications for ICD? The indications for ICD is unexplained syncope or near syncope felt to be arrhythmic in etiology, inducible sustained VT, right? If a patient is diagnosed with cardiac sarcoid. So in this case, the problem was we still do not have a diagnosis of cardiac sarcoid. So based on our discussion, they decided to wait because we told them that this is lower specificity, and they brought him back after a few months to repeat the study. So with a better diet, you can see there's no new perfusion abnormalities, no focal uptake in the heart. You still see the mediastinal nodes. This is a negative scan suggesting there's no cardiac sarcoid. So ICD was avoided in this case. So how does cardiac sarcoid look like on FDG? Patchy uptake, you can see this. Mediastinal lymph nodes, right ventricular uptake is a poor prognostic feature. On the bottom is a negative FDG scan. You can see background activity, no focal myocardial uptake. Classic MR, you can see focal LGE, that's mid myocardial, predominantly affects the anterior septum at the base or inferior infralateral walls at the base. Just remember that T2 weighted edema imaging is insensitive to diagnose, they should say T2, is insensitive to diagnose cardiac sarcoid. So what about FDG? It is accurate to diagnose sarcoidosis. The area under the curve for diagnosis is 0.293. It's also helpful, both perfusion and FDG are helpful to predict prognosis. If both perfusion and FTG are abnormal, these patients have the worst survival, free of death or VT. If both are normal, those patients have the best survival. If either FTG or perfusion is abnormal, then in between survival. What about late gadolinium enhancement? There's a study showing that LGE portends worse event-free survival, presence of delayed enhancement. Meta-analysis, again confirming the same thing, that patients who have LGE have higher risk of death or ventricular arrhythmia. How do we use imaging to guide treatment? Basically, symptomatic therapy of heart failure, arrhythmia, and heart block. You use imaging to look at LVEF and LGE to make ICD decisions. Specific therapy for sarcoid is driven by presence or absence of inflammation. MRI cannot diagnose inflammation at this point, so you do need FDG PET imaging to identify inflammation. And once inflammation is identified, these patients can be candidates for immunosuppressive therapy. If there is no inflammation, FDG scan is negative, and the findings are consistent with fibrosis, then those patients can be spared of anti-inflammatory therapy. How do we use FDG to guide patient management? Look at ejection fraction. We also look at the perfusion defects. You see if the perfusion defect is getting worse over time. You look at FDG, all right? So this is a patient with baseline and follow-up. The FDG scan looks identical on relative perfusion imaging. But because this is hotspot imaging, you do need more quantitative metrics. So SUV max in the heart, 10.3, improved to 7.6. The volume of inflamed myocardium, so we use a threshold of 2.7 and calculate the number of pixels in the heart above the threshold of 2.7. And using that, we see total volume of inflamed myocardium decrease significantly. Why do you still see activity in the myocardium? You see it because this is relative perfusion imaging and your scan is normalizing to that. So the next speaker, Dr. Piotr Slomka, sent me this slide this morning. So his group has a recent publication on this topic with automatic quantitation using software. So here's an example of how they can use PET-CT together, FDG, to quantify the amount of inflamed myocardium. So the key findings of this study are to show that as opposed to visual or SUV max, when you look at threshold-based metrics, the volume of inflamed myocardium 2.7, which is what I mentioned, what we do in our lab, we showed that within scan metrics of target to background ratio seem to work better. So if you look at LV to blood pool ratio 1.3, 1.5, or volume of inflamed myocardium, and they call it, I think, cardiometabolic activity, these metrics seem to perform better than an absolute threshold, and that's not surprising because depending on your preparation, your FDG uptake in the blood pool activity may vary from scan to scan. So rather than comparing an absolute metric, a target to background ratio is going to do better. Now switching gears to amyloid. So what is amyloidosis? This is a group of diseases, large biochemically and clinically heterogeneous group of disorders, which are caused by protein misfolding. Once the protein is misfolded, they form these beta-pleated sheet structures, and the structure is indistinguishable, independent of the precursor protein. So when these amyloid fibrils deposit in the heart, you can develop cardiac amyloidosis. The most common manifestation is heart failure with preserved ejection fraction. In certain hereditary forms, you can develop autonomic dysfunction, atrial fibrillation, heart blocks, thromboembolism, microvascular dysfunction, angina, and claudication are all features of cardiac amyloidosis. The two main forms of amyloid that affect the heart, one is called the immunoglobulin light chain, the other is called transthyretin or ATTR. The light chain form of amyloid is the bone marrow disorder with a rapidly progressive course, treated with chemotherapy. Median survival, if untreated, is about 6 months. What about TTR? It comes in two flavors. One is wild type or age-related TTR amyloid, and the other is mutant or inherited form of TTR. About 4% of African Americans have a TTR gene mutation. These patients present with heart failure, autonomic neuropathy, or both. This disease progresses slowly, and the treatment is stabilization of TTR or liver transplant until recently for the hereditary form of disease. Median survival here is about 7 years after onset of heart failure. Here's 2 studies showing the outcomes in patients with light chain and TTR amyloid. Here's certain groups of patients with light chain amyloid, right? This is called Mayo stage 4. In this group, you can see if untreated, the median survival is about 6 months. On the other hand, look at the right-sided graph. In patients with ATTR cardiac amyloidosis, the median survival here is about 45 months. So not only is it important to figure out what type of amyloid it is, because your treatment depends on that, but it's also important to know because if it is AL, then it's urgent. You need to treat very rapidly compared to TTR, where you have time to make a definite diagnosis. AL amyloid patients have a lot of novel treatment options. Melphalan plus stem cell transplant was used previously. CyBOR-D was the most current treatment, but now increasingly we are seeing that a lot of these patients are receiving these monoclonal antibodies, daratumumab, with very high success rates. ATTR can be treated using 2 forms of therapy. One is TTR suppression, and these are genetic drugs, patisiran and inotersen. The other is TTR stabilization, and tafamidis falls into this group, diflunisal, doxycycline, TUDCA. So each of these drugs can reduce formation of TTR amyloid new fibril, but the existing amyloid fibrils are not removed by these treatments. Therefore, still novel agents or antibodies to remove the fibrils are probably necessary. So because of the different treatments, different outcomes, accurate diagnosis as well as typing of amyloid is essential for disease management. So what are the imaging targets in cardiac amyloidosis? So if you take a look at the schematic, this is a normal heart, and you can see the heart becoming very thick here, both left ventricle and right ventricle. In hypertensive heart disease, the myocytes are hypertrophied, and you can see a large voltage ECG, and this is all because of cardiomyocyte hypertrophy. In contrast, in a patient with infiltrative heart disease, such as amyloid, you can have these fibrils deposit in the extracellular space, and as a consequence, you have increased LV mass without necessarily increased LV voltage on ECG. These amyloid fibril deposits can be accurately imaged by targeted amyloid SPECT tracers or PET tracers. You have bone-avid compounds, pyrophosphate, DPD, HMDP. Aproteinin is no longer used in clinical practice because of concerns of bovine encephalopathy. Technetium labeled SAP is not widely available. Only some countries have that. What about PET tracers? You have C11 labeled Pittsburgh B compound, F18 labeled florbetabeer, florbetaben, and flutimetamol. All of these compounds image the amyloid fibril, therefore provide a very specific signal of amyloid, whereas MR and echocardiography can measure increased wall thickness or expanded ECV with MR. And these features are not specific for amyloid and can be seen, for example, wall thickness can be increased in hypertensive heart disease, and expanded ECV can be seen in other forms of infiltrative myopathy. And in fact, most forms of cardiomyopathy have some degree of ECV expansion, although in amyloidosis, the ECV is almost 0.4 or greater, very massively expanded. Echocardiography has typical features: granular sparkling myocardium, thickened valves and interatrial septum, biatrial enlargement, small pleural and pericardial effusions, restrictive filling pattern, mitral inflow Doppler, pulmonary vein Doppler, tissue Doppler imaging of the mitral annulus. When you look at strain imaging, you can see this characteristic pattern of hypercontractile apical segments with decreased longitudinal strain in the mid and base of the ventricle, resulting in this pattern of apical sparing of global longitudinal strain that has been described to be typical for cardiac amyloidosis. However, the key point to remember is all these features are insufficient by themselves to distinguish hypertrophic heart disease from AL or ATTR cardiac amyloidosis. So although the echo may suggest the presence of amyloid, by itself it's not sufficient for diagnosis and for treatment. What about MRI? MRI also provides structural features and tissue characterization, as with echo. You can see thick ventricles, very similar features, pericardial pleural effusions. The classic feature on MRI is this difficulty with nulling the myocardium. So late gadolinium enhancement, typically diffuse and transmural, sometimes atrial delayed enhancement, which is a very specific marker of amyloid. ECV expansion, where you look at T1 relaxation times before and after administration of gadolinium contrast. And if you know your hematocrit, you can calculate ECV. Then in patients with renal failure or creatinine elevation, you can use non-contrast native T1 mapping to identify or suspect amyloidosis. But the key again is all of these features are insufficient to distinguish AL from ATTR cardiac amyloidosis. What about radionuclide imaging? So you have a number of SPECT compounds, bone avid tracers, PYP, DPD, HMDP. Hereditary disease was previously diagnosed using I-123 MIBG, SAP, the PET tracers that we discussed earlier, and then new tracers against heparin sulfate proteoglycan. The key advantage of these targeted molecular imaging is that these techniques can provide a virtual histology image of the entire heart. So not only do they show structure, but they tell you what exactly is causing the abnormality. So a few slides about targeted imaging with PET. There are a number of publications on this topic. I'm just sharing with you some of our experience. This is a control patient without amyloid florbitapir. Here's a patient with light chain amyloidosis showing diffuse lung uptake. And here's your axial image showing the same. The parotid uptake, thyroid, tongue uptake, all of which are organs that are involved in patients with light chain amyloidosis. Here's the lung uptake patient again, right? In addition, we have a recent evidence suggesting that florbitapir or molecular imaging using amyloid tracers may detect early amyloid even in patients with normal wall thickness, normal ECV. So here's an example of normal wall thickness and normal cardiac biomarkers. So here you have 4 patients, active AL amyloidosis. This is patients after treatment, remission, active cardiac amyloidosis by retention index, and this is non-cardiac amyloid. So if you look at these 2 columns, these patients were both had no significant LGE, normal wall thickness, and normal cardiac biomarkers. But when we did florbitapir imaging, we can clearly detect early amyloid in this patient and no amyloid in the other patient. So this is just now giving us some suggestion that systemic amyloid can affect the heart, and early detection is possible with molecularly targeted imaging tracers. What about the bone compound imaging? This is a large study that you're familiar with probably, almost 1,500 patients, 378 with endomyocardial biopsy. These are data on 109 patients with pyrophosphate imaging. If you focus on these 2 bars here, in patients who have grade 2 or grade 3 pyrophosphate uptake in the myocardium, if AL amyloidosis is excluded, then the diagnostic accuracy for cardiac ATTR is very high with a specificity of nearly 100%. So these study results led to the new knowledge that if you can have a patient with heart failure where you exclude light chain amyloidosis and you see definite uptake in the myocardium of grade 2 or grade 3, then these patients most likely have cardiac TTR amyloidosis. So the other parameter that is reported in the literature is the heart to contralateral ratio. If you look at a heart to contralateral ratio, you'll notice that patients with ATTR have a much higher heart to contralateral ratio compared to AL. So more than 1.5 is ATTR and less than 1.5 is AL. The heart to contralateral ratio is also prognostic. Patients with a normal HCL less than 1.6 have a better outcome compared to patients with a HCL ratio of more than 1.6. Given this new knowledge, a number of investigators have started performing screening studies looking for cardiac ATTR amyloidosis, and they showed that the prevalence of ATTR in elderly patients with heart failure ranges anywhere from 10% to all the way to 29% in postmortem TAVR hearts. All of this is suggesting that ATTR cardiomyopathy is prevalent in older individuals with heart failure, but substantially underdiagnosed currently. So how are we currently using PYP imaging? Patient with heart failure presents for evaluation. You look at the heart, bright and sparkling myocardium. This is a classic amyloid appearance. Then you perform a PYP scan, SPECT-CT. It shows biventricular uptake and confirming that this is amyloidosis. Unfortunately, patient did not survive. Autopsy shows this massive LV mass increase, and all this green is amyloid. The yellow is cardiomyocytes, and you can see this extensive amyloid deposition within the myocardium. Early TTR cardiac amyloid can be detected. Here's an example of a normal looking heart, normal tissue Doppler imaging, but pyrophosphate imaging shows intense biventricular uptake. So why did this patient get this scan? The patient got a scan because she is 59 years old with a TTR gene mutation, and her father died of TTR amyloid. So she wanted to participate in a research study for treatment of ATTR amyloid, and that's why she got this scan. The third key point is remember that a PYP negative scan in a patient with typical features on echo and on MRI, right? A negative PYP does not exclude cardiac amyloidosis, all right? So when you face a patient like this, where the echo and MR are classic, PYP is negative, you need to consider further evaluation. This patient underwent floor beta-peer PET-CT, which showed intense uptake in the myocardium, was diagnosed with light chain cardiac amyloidosis. Some forms of hereditary TTR amyloid patients may manifest a negative bone tracer scintigraphy. So remember that it's not just AL, but some forms of hereditary TTR may also have a negative bone scans. What about MDP? A lot of sites use MDP for bone scanning, and MDP does not exclude TTR cardiomyopathy. Here's a patient, classic echo, classic MRI with LGE, but MDP is negative. He came back, we performed PYP, and you can see intense uptake in the myocardium, confirming that this patient has a positive PYP scan suggesting ATTR cardiac amyloidosis. So the last 1 minute, I know I'm close to my time here. I wanted to share with you some consensus recommendations on imaging in cardiac amyloidosis. So multiple societies got together and developed these recommendations. The diagnostic criteria for amyloid is based on either endomyocardial biopsy or extracardiac biopsy. It could be fat pad, bone marrow, any organ biopsy, renal biopsy. And in these patients, if you have typical imaging features, then that confirms the diagnosis of amyloidosis. If your extracardiac biopsy suggests that the patient has light chain amyloidosis, then if they have an abnormal NT-proBNP or troponin T, that confirms cardiac AL amyloidosis. On the other hand, in the bottom panel, you can diagnose TTR amyloid without biopsy using imaging alone. So in a patient with grade 2 or grade 3 PYP, if you exclude AL amyloidosis using serum and urine immunofixation electrophoresis and serum free light chain assay, and if the cardiac features are classic for amyloidosis, then you can diagnose this patient with ATTR without a biopsy. So who to test for cardiac amyloidosis? Older patients, particularly African Americans with HFpEF or LV thickening, non-African Americans with HFpEF and LV thickening, low flow, low gradient aortic stenosis, heart failure with unexplained peripheral sensory motor neuropathy, sensory neuropathy, known or suspected hereditary cardiac amyloid, as in our patient with a family history, monoclonal gammopathy or elevated light chain levels, progressive symptoms in a patient with known AL or ATTR, and other high-risk features such as carpal tunnel syndrome, biceps tendon rupture, or lumbar spinal stenosis. So in conclusion, infiltrative heart diseases, cardiac sarcoidosis, and amyloidosis are highly fatal and unfortunately substantially underdiagnosed. Emerging novel therapeutics now increase the urgency to accurately diagnose and treat these diseases. Structural imaging, echocardiography, magnetic resonance imaging, identify the effects of infiltration on cardiac structure and function, but molecular imaging techniques using radionuclide tracers identify the specific pathophysiology and can help guide management and biopsy decisions. Imaging combined with serum biomarkers can advance early and accurate diagnosis, stratify risk, guide targeted management of infiltrative cardiomyopathies to improve clinical outcomes of affected patients. Thank you very much for your attention.
Thank you very much, Dr. Dorbala. Dr. Dorbala, we have the questions at the end of the presentation, please. Doctora Isabel Carvajal, si nos haría favor de presentar a nuestro siguiente ponente.
Gracias. Claro, voy a presentar al doctor Piotr Slomka. Él es un científico muy reconocido, tiene un doctorado en biofísica médica, dirige un laboratorio de inteligencia artificial en el Cedars-Sinai y es profesor adjunto también en UCLA. Trabaja principalmente en el desarrollo de algoritmos de diagnóstico y predicción de eventos cardiovasculares con imágenes cardíacas, principalmente SPECT, PET y CT, angiotomografía de coronarias. Un gusto, doctor Slomka.
Gracias a todos. ¿Podrían escucharme bien?
Escuchamos.
Sí, ¿podríamos compartir mi pantalla?
Yeah, go ahead. You can share.
Yeah.
Yeah. Try your computer.
Yeah. ¿Podrían ver mi pantalla ahora? Sí.
No, todavía no. Aún no.
No. Porque dice que it shows that I am sharing. Un momento.
Can you try again or?
Yeah, I can try again. Resume share. Stop share and one more time. Share screen. Share. Yeah? No?
Yeah. Dr. Dorbala, can you stop sharing your screen?
Right. That's what I'm seeing, actually. Maybe I need to stop sharing. That's what I'm trying to see. Hold on. Stop share. Okay, try now. There you go. Yes.
We can see your slides.
Ahora eso está bien. Ok, gracias por invitarme por esta conferencia. Y disculpen que no puedo hablar en español mucho. Todo esto va a estar en inglés, pero estoy muy agradecido por Eric y todos mis amigos en México para hablar. So, I will talk today about the work we do in artificial intelligence at Cedars-Sinai. And First of all, I just like to advertise, and I'll show you at the end also, we are looking for people who want to work with us in artificial intelligence. You know, we're very happy to invite also clinicians, not just scientists, but also clinicians. And I will show you what kind of work we are doing. So then we'll see. Now let's see. So I will talk today about two topics which we are very familiar with here with nuclear cardiology and CT. We work a lot in these areas, and I will describe to you today just a little bit of the things we try to do AI and actually give it to the clinicians. So this will be more about how we give it to the clinicians and how the clinicians could use this tools. So nuclear cardiology is an excellent area to work in AI because we have a lot of data. We have 7 million scans per year in the United States, 15, 20 million worldwide. We have data well quantified. All the data are on the computers. We can do all the analysis. We can do perfusion, flow. We can also get a lot of extra variables from ECG, clinical, and we can then present to the doctors some important findings. So we started a big project. We involve a lot of sites, including sites around the world, not just in US, where we collect a lot of data, because in AI, the most important thing is to have very well-defined data. And here we collect images, clinical data, and outcomes, such as major adverse cardiovascular events. To date, we collected about 24,000, almost 30,000 now, as I checked yesterday, we have already in-house. The goal is about 50,000 cases with images, with outcomes, with all the clinical information, and we're finding what else we can find out more accurately from those images. So if we now, so everyone is probably familiar here with this kind of display, polar map display. So this is what we do for, so this is what we do here for, we map left ventricle on this polar map. We can see abnormal normal polar maps in abnormal polar maps. And we then try to diagnose from this. So one of the applications, the things we're trying now is to use this kind of polar map display to use deep learning. And so we had two publications recently on this. One is in JACC imaging, one in JNM. And I will describe to you just a little bit more of the new things we're doing and how we try to put it in clinical use. So this particular application, this was done on a upright supine camera. We have upright images, supine images, and we try to predict which vessel has a high probability of obstructive disease. And so actually, this is a new version here. We're just improving this all the time. This is so this is one of my research associates working with me, Ananya Singh. We developed this kind of new neural networks. These neural networks are fed directly these polar map images. So this is a kind of a typical schematic where it goes through many layers, many layers of these networks, and then predicts for the reader, for the physician, predicts and provides probability of obstructive disease in LAD, LCX, RCA. We also add some little bit of clinical information, but very little, everything what's in the images. So we don't want to enter any information. We have gender, BMI, age, and heart volumes. This data is the story in images. And then we can actually explain to the physician what the computer is finding and where. So let me talk about this for a little bit. So one of the new techniques, which everyone talks about, the artificial intelligence as a black box, that this is something computer will predict and you will just get an answer. But I think in clinical use, what we really do, we really want clinician to understand fully what the computer is doing and why. So a lot of the things we try to do for the clinical application is to explain. And one of the explanations would be to, for example, show something on the polar map where the computer thinks it's abnormal. So this is this famous paper from computer science, GradCam. It's called GradCam by Selvaraju. And here it shows you, this is like sort of back propagating through the network. And this is famous in this deep learning world where people do this for this picture detection, where it shows, well, this is not a cat, and it shows on the image what what it tells it that it's not a cat, and what it tells it that it's not a dog. And we can use exact same kind of algorithms to show on the image what actually was causing a probability, high probability of obstructive disease. So those are the kind of new things we are putting in for the doctors to use it. And so the recent versions, this is Yuka Otaki, one of the clinical fellows at our institution and a project scientist. She works with this, you know, on the clinical side to put everything together. And we have here, you know, our AUC, this is area under the curve for detecting of obstructive disease. You can see how much better it is than, for example, visual reading. This is a visual reading from experienced physicians from multi-center studies. And this is the quantitative analysis, and this is the deep learning. And here, if you set a specific threshold, for example, of certain specificity, the same as the doctor using segmental stress scoring, then you can see that improvement in specificity, in sensitivity, can be about 8%. So, and this kind of tool is now like, so this is what we have now in you. Maybe some of you are familiar with the QPS software, which is used around the world. So we're now putting it in a research mode for clinicians to be able to display it like this, show where, where this probability is high for which vessel and which segments are involved using this GradCam technique. And then this can be, compared to the traditional quantitation, and also the scoring can be done. So this can be done in about 10 seconds on the computer system with a standard scan. So this is how we see this deep learning, all these things we're doing, how this can be actually put in clinicians' hands. Is another example here. This is normal visual analysis, but this is kind of upright supine images. People think maybe there's some defect in the apex, but actually was read normal. There is a high probability of LAD disease, and indeed that patient had proximal 90% stenosis in proximal LAD. So we have many examples like that in this thousands of cases we have in the registry. Another example here, 68-year-old female, 80% stenosis in proximal and mid-left LAD. And you can see here, again, difficult scan because it's like it shows abnormal on upright, maybe normal on supine, but the computer is evidently sure there is a high probability of disease here, in 82% probability that it's an LAD defect, LAD invasive obstructive disease by invasive angiography. And TPD in this case was different for upright and supine. So this is one example. The other example is that we can actually add more clinical information into the data. So doctors use some, not just like the age of the patient, but more, but maybe something about the ACG test, maybe something about did the patient have diabetes and so forth. So you can add a lot of more information. And for example, in this case, would make sense to predict something like MACE. Or risk of major adverse coronary events. So this is the paper we published in 2017. And we're now actually trying to put it in the clinical use, like those kind of ideas. So here we see that if you do this, you can, first of all, this is called a calibration graph, where we show that what kind of events, what MACE events was actually happening. And the green line shows what it was predicted by the computer. And you can see for every percentile of risk, from low risk to high risk here on the x-axis, for every percentile, it was tracking that what was observed versus what computer predicted. So that is important in machine learning. You want to show this graph always. The other thing which was kind of striking here is that in that paper, we published that people with the highest risk, 95th percentile risk of machine learning score, 19% of these people were actually read as normal by the visual findings. So this tells you that that kind of tool can highlight some scans which supposedly are normal, but they can highlight this high-risk patients for whatever is a strategy for this patient will be for treatment. So one of the clinical applications, the immediate clinical application, which we plan to use it for, is the stress only. I don't know how many people in Mexico do stress only imaging, but it is not something is often used in United States. And I think, for example, there's a classic paper from 2010 by Dr. Mahmarian group showing that you can use this kind of criteria to select which patient would go for stress only scan and be canceled rest scan. But this kind of thing is hard to do. It's sort of hard to do clinical use, because you will have to know all these things right away. Physician would have to be available right when the stress scan is done. So this is a perfect algorithm to find the low risk patient automatically, immediately for the technologies. So here's an example of a scan, a stress. This is one of our database scans from our database, and you can see here that we have the 53-year-old female, BMI 51, exercised, and a peak heart rate. So those are the kind of key clinical informations which are used by the system. And here's a scan, and you see upright scan is abnormal. It shows a TPD abnormal. It's normal on supine. It's a problematic case. So physician in this case would not cancel the rest scan. So I don't know if we can have a chat box, but like if you can see how, what you would do here in terms of canceling or not canceling. What would you do? The cancel rest scan, not cancel, need attenuation correction, and carefully assess all clinical factors. So I don't know if I can see the chat here, but I don't know if what people think there in this case. So
2 or 4.
4, yeah, exactly, yeah, number 4. So this is what we have in the computer. The computer, the AI will do exactly this. And here, so AI will give you a risk score. The risk score is very low risk score of 3% over 5 years of MACE. But more importantly for the physician, this case will be explained why that case is a low risk. So not on a group of our other cases, but this case, and tells you its age is pretty low, high body mass index somehow in this case, because it probably thinks it's an artifact, whatever it sees on the image, it is protective. And all these other features, the female in this case. So all these features, and of course the TPD is raising the risk, but you can see that kind of graph, and you then understand like why the computer is deciding that patient is a low risk patient. So you have it all quantified and you get the risk. This patient had no MACE in 7 years, but by this clinical criteria will be obtaining rest scan. So this paper is just came out. Will come out in about a week in EAJ cardiovascular imaging. It's not yet available, but I can send you preprints. And it shows that kind of technique is more accurate for MACE prediction. This is medical diagnosis, the sort of normal scan. This is TPD. This is this kind of MACE prediction. And if you were to cancel rest scans by this kind of technique, you would get 60% of scans canceled with the risk of those patients 1.4%. If you were to want to cancel 60% of scans by visually normal scan, you can do that, but your MACE risk will be higher in this patient, which are chosen by visual analysis. So, and you can choose with the ML machine learning, you can choose whatever threshold cutoff, how many scans you want to cancel at what risk. Basically, you can prescribe it and use it. So this is the kind of techniques. This is Dr. Hu from Taiwan, clinician scientist who's worked with us here at Cedars-Sinai. So in this case, this was written up at Aunt Minnie. And actually right now in the US, we only cancel 3% of the scans, and we show that with this kind of AI approach, we could cancel 60% of scans. So that could be a big savings in money, in radiation, in physician time, and so forth. So now just moving on a little bit to the CT, to show you some of the things we do in CT, just a little bit. This is the graph from Cedars-Sinai. You see that nuclear cardiology is going down, the CT is going up. I don't know if it's the same in Mexico, but this is the trend we see. So we really have to work with CT, and luckily nuclear cardiology often comes with CT, with PET CT, SPECT CT, so we can use best of both worlds. So in CT, there's 2 areas. One is the calcium scanning, for example, calcium scanning, and those scans are actually available also as attenuation maps. So that's something to remember on nuclear scans. And there's a lot of work doing, on automated quantification of calcium lesions. But I want to show something which Dr. Day here at Cedars-Sinai does, has a grant at NIH for this. And this is actually an interesting concept that by deep learning, we can quantify very exactly the pericardial fat, the fat, inside the epicardial fat, the fat inside the pericardial sac, And this kind of thing can be done manually, of course, but the physician will have to manually go slice by slice. This would take a very long time, maybe half an hour for a case, to do it accurately. But with deep learning, we teach the computer by expert tracing in many, many cases, and then the algorithm can do it exactly like the expert for every new case. So so here is an example of Dr. Day in our lab. This is the software we've built for this. It's called QFAT. This software is used in some research sites. And you see here, this is the expert annotating, finding this pericardial fat in many slices manually. That took them 10 to 30 minutes per case. This is the deep learning, is exactly almost the same. And you can get this, it will give you these contours which can be adjusted if needed. So that's another example. It takes about 20 seconds, or if you have a GPU, graphical programming processing unit, then you can do it in less than 1 second. So how that can be used clinically? For example, here you have the example of the calcium. Everyone knows how powerful predictor it is. But if you add that fat quantified automatically by deep learning, you see that for low calcium, the low fat or high fat here, the epicardial fat, will make a big difference in risk. For high calcium, same thing. This is just published in Circulation Imaging 2020. So those are the kind of examples how you can use the AI techniques in real sort of clinical practice. So just to kind of finish off on some interesting things, everyone is now interested in COVID. We all work from home, and I don't know if you've seen this paper from Dr. Albano from Italy, where they actually see COVID on the PET-CT scans. This is JNM publication. You can see on PET-CT scans from, directly from the CT maps. So we actually now are starting a project at Cedars-Sinai. So this is a new thing, not yet results, but just so you know, we also work with this. We will work with finding COVIDs, these ground glass opacities on the CT maps, and then try to build it into the nuclear cardiology software. So something which you will have for the cardiac imaging people or nuclear medicine. So you can see this as an incidental finding, and you'll be able to display it and then quantify and also diagnose and automatically detect, because I think people don't pay attention necessarily to these things when they look at nuclear cardiology scan. So this is what we're currently working on, quantifying the ground glass opacity consolidation and so forth. This is what we're spending our time on right now. So the difficulties in AI, so just a couple of slides with the difficulties, is that the physicians have to understand what data were used to train the system. Because this is an example from PLOS Medicine, a ZEC paper, very interesting paper. They used AI to detect pneumonia on x-rays. And they found they had Mount Sinai cases and some other hospital cases. And they found that pneumonia, for some reason, was showing in the shoulder. So even for me, I am not a physician, but I know that pneumonia is not in the shoulder, is in the lungs. So something is wrong. So if you see this explanation, you see this, the computer is able to, tell you where it's seeing something. You can see what's going on. So in this case, the data from this hospital has a special token, metal token here, which was seen on the X-ray, and that token was only from that hospital, which was very high incidence of pneumonia. So it was because of that it was suggesting this is pneumonia. So we have to avoid this kind of cases. And eso sucedió 2 millas de mi casa, as the crash. So a Tesla crashed into the red fire truck. Because it was not trained on on fire trucks. So the autopilot, we know we have to use it like this, that we control it. So all these new things, the doctor controls it. Is not a fully automated system. And we believe that the software we develop will be for the doctors, will be something to look at and to take into consideration, but not like totally overtake, because we can have the big trouble in such cases. So thank you very much. It was a pleasure to present, and I'll show you, as I said, we like to advertise the position at Cedars-Sinai.
Thank you, Pietro.
Thank you very much. ¿Alguna pregunta, any question for these great professors?
Sí teníamos una pregunta del chat box. For Dr. Sharmila, are you there?
Yes.
I have a question from the group chat. What is your expertise, your experience about imaging sarcoid with somatostatin analogs?
Right. So that's an excellent question because of all the special dietary preparation needed for FTG for sarcoid, a lot of people are looking into new tracers. We have a little experience with somatostatin analogs. One of our fellows, Paco Bravo, did a research study when he was here with us in 10 patients, all of whom underwent FTG PET for sarcoid and also got dotatate, I believe, gallium-68 dotatate. I don't know the true answer, but I think you see less signal with the new tracers compared to FTG. So it's more specific likely, but the less signal may just be because it's a receptor imaging agent, whereas FTG will image inflammation, it'll image maybe microvascular ischemia from the granuloma compressing that area. It can image hypoxia and other things. So the effects of hypoxia and ischemia on the myocardium. So for all these reasons, I think in general, what we notice is the signal intensity is low. A number of other people have tried it, but I don't think anyone has definitively shown that these agents work better than FTG.
Okay, thank you. And I do have a question, my own question. Do you think there is a possibility? What is the chance to have a normal MRI for sarcoid, but abnormal? I mean for amyloidosis. Normal MRI, abnormal PEEP.
So this is, your question is for sarcoid or for amyloid?
For amyloid.
For amyloid, okay. I think the possibility exists, but it's not very high. So in the study that I showed you, where we looked at patients with normal wall thickness, negative cardiac biomarkers, systemic AL amyloid, we saw that almost all of them had florbitapir uptake in the heart, and about half of those patients had uptake as much as active AL patients, right? When we go back and looked at their ECV, the ECV is not normal, but it was not very abnormal. It was, the ECV was somewhere around 0.31, 0.32, which is a non-specific by itself. But when the ECV is combined with the florbitapir signal, then we are more confident the two together likely represent early amyloid in the heart. So the advantage of using the two together is that you have structural information from ECV and molecular signal from the PET tracer.
Okay, thank you.
Bienvenido, doctor Eric Alexanderson, doctora Aloha Meade. Muchas gracias por la invitación. Estamos disfrutando mucho
buen día.
el webinar.
Okay.
Doctor Berros.
Dr. Berrios, are you there?
Doctor Berrios, ¿alguna participación?
I think he's not here anymore. Well, Dr. Slomka, I have a question for you. You gave us a very interesting talk about artificial intelligence, and you have your own imaging laboratory. What you showed us was a great talk. And do you think that imagers, cardiologists around the world should be worried about being replaced by this artificial intelligence?
No, I don't think you should be worrying. I think you should be thinking that you will be getting a better tools. Better tools. You'll be getting an aid, and I think so many times we ask. That's why I showed the slide with the Tesla crashing, because I think cars is one thing, but in medical diagnosis it is much further. I think we will use these computers, as aids, and even like we use it now. In radiology, I work now with this COVID, so they use it a lot for pulmonary nodule detection. It's actually used. There's companies already they have this, and it is a great aid. It helps them. It finds them. It locates them. These cases. It sorts them, like, so they have the most important cases on the top. All these things. So it's just your work will be easier. Will be better checked. You'll make less mistakes, but it is not going to replace you. I think at the end, if we can make nuclear medicine 5-10% more accurate, I think everyone wins. The doctors who do nuclear medicine also win, because otherwise there's other competition, right? They can take over by, you know, just doing blood tests or whatever. So we need to do our techniques as accurate as possible, and whatever it takes. I don't think it's possible for the doctor to take 100 variables and really weigh and compute that risk. That's not what the doctor is, to work with the patients and to understand, explain to the patients, and take into consideration these risks which computers will present. So.
Oh, thank you. That's good news.
Yeah. Okay.
Amazing, Dr. Lomka. Thank you.
Thank you. Thank you.
Muchas gracias a todos. Realmente impresionante lo que hemos visto en esta tarde, en esta presentación. Muchas gracias, doctora Alexanderson, doctora Lojameabe, por la invitación. Y pues creo que con esto podemos dar cierre a este webinar.
Antes de cerrar, quiero agradecer, por favor, al laboratorio EIDOS por su apoyo para esta plática. Muchas gracias.
Chao, Sharmila. Chao, Piotro.
Gracias
por
invitarme.
Thank you so much. Be safe,
Es un
everyone.
placer.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
See you soon. Bye.